Good evening everyone and welcome to another webcast brought to you by Optometry Australia. Tonight we're talking about AMD and update on best practice. It gives me great pleasure to welcome you all tonight. As you can see on your screen, we've got 4.5 points on offer. That'll be face-to-face and clinical with 70% completion of assessment questions. For attendance only tonight, you'll get 3 points and they'll be automatically attributed to your member portal in the coming days. Now, if you don't get the questions emailed to you in the next 48, 72 hours thereabouts, please contact the National Office. Occasionally what can happen is that you can opt out or unsubscribe from OA National's emails, and so then you might miss out on getting that email. So please contact us if that happens. Now, if you have any technical difficulties tonight viewing the webcast, please give the number on your screen a call, and the Redback people will be more than happy to just to help you out there. Now, of course, as always, we encourage you to ask as many questions as possible. Our esteemed panel tonight will be more than happy to answer as many questions as we can get through. So please keep them coming through. Type them away. They're anonymous questions. We won't know what your name is, but we'll be able to answer as many questions as we can, both on the clinical and the non-clinical areas. Now, for those watching on phones or tablets, or those who just prefer the slides next to them as to follow along, particularly those that have pictures and those sort of things, the presentation slides are available for you under the Resources tab. So please go to the Resources tab at any time and download those files as a PDF if you like. There are other resources under that Resources tab as well, including the Clinical Practice Guide that Optometry Australia has just recently released, and that we'll be talking about in a few moments' time. We've also got a resource that Novartis has provided. We'd also at this point like to thank our sponsors, Novartis, for being able to sort of sponsor and support Optometry Australia in bringing you this event. The more support we can get, the more we're able to provide this sort of service and this sort of education for you, the members, in a convenient fashion. Now, obviously, we get a lot of questions about whether or not you're going to be able to watch this recording later. Of course, we host all our webcasts on our website, and they're a member-only resource. So if you're a member, you can log in and re-watch them at any time. That's also sort of, I guess, handy, particularly if you're trying to answer the questions in the coming days. If you wanted to go back and see what Carla or Angelica were talking about, you're more than welcome to go back to that. And again, we host a recording in probably about 48 hours' time, so stay tuned for that. Now, I can't stress enough that if you're watching in groups or multiple people that have registered or watching together, please ensure that each of you log in separately, even if you put it on mute. That way we can see that you've logged in, we can see the time you've logged in and the duration that you've watched for. Now, we can only provide CPD points based on the duration of watching, and that's based on the post-event reporting that we get. So please bear with us if there's any glitches or any issues, but we do have to go on that post-event reporting. Now, you'll see under the resources and on your screen as well that there is a survey that Novartis has put to optometrists. This survey is one that Optometry Australia is happy for Novartis to put to members, to Optometry Australia members and optometrists, essentially trying to understand better what optometrists know about AMD and you know, where it is that optometrists sort of would like to benefit from further. Now, when we return from our next break, we're going to have Carla Abbott talking to us about the new AMD Clinical Practice Guide that Optometry Australia has recently released. So stay tuned with us, please.
Since Earth's beginning, single cells have evolved into diverse and complex biological machinery, enduring 5 mass extinctions until humans first appeared. Yet it wasn't until we lived together in numbers that health entered the collective consciousness as we witnessed our own fragile mortality. And then, within the last few centuries, we began to think of health as something we can change. We discovered modern medicine. With it, glimpsed that it might just be possible to bend the curve of life. Now, right now, there's another shift happening. A pivot point in big history where data and technology are transforming every aspect of our lives. Nowhere is this pivot point more remarkable and more vital than in the world of medicine, our world. So as we continue on this grand human project to further bend the curve of life, we are issuing new challenges. How do we intervene earlier in disease? How do we prevent chronic diseases from occurring in the first place? How do we enable anyone, anywhere, to reach their full human potential within an ever-increasing lifespan? We aspire to reshape our impact on human life. This is the science of transformative technologies, where the ultimate medicine is the power to preempt disease, where rigor meets imagination, where creativity finds the cure. We are Novartis, and we are reimagining medicine.
Welcome back, everyone, and thank you again for joining us on our AMD update that Optometry Australia is presenting to you tonight live from Redback Studios in Melbourne. Now, it gives me great pleasure to introduce our first speaker tonight, Dr. Carla Abbott. Now, Carla is a research fellow at CERA, the Centre for Eye Research Australia, and also a teaching clinician at the Australian College of Optometry. Carla has a special interest in structure and function of the retina and the optic nerve. In 2018, Carla was asked to be part of a working group that developed the Optometry Australia AMD Clinical Practice Guide. Now, Optometry Australia are quite proud of these clinical practice guides, being able to aid and assist practitioners with handy and useful chairside guides to be able to assist them and aid them when it comes to their practice of optometry and disease management. We also have other clinical practice guides around diabetes and glaucoma and paediatric care, so please visit our website to find those at optometry.org.au. Without further ado, I'll introduce Carla Abbott to take it away. Hi, Carla.
Hi, Simon. Thanks very much for the kind invitation to be here and the introduction. And of course, I'm presenting on behalf of the Optometry Australia AMD Clinical Practice Guide Working Group, which was comprised of a number of people, including Karen Hart as the chair, Lauren Aiton, Sue Kalf, Jaja Lek, Angelica Lai, Gary Page, Bill Robertson, Rebecca Tobias, and myself. So let's get going. AMD, as many of you know, is the most common cause of irreversible vision loss in people over 50 in Australia. And it does cause loss of central vision, with a socio-economic burden in Australia over 5 billion, and has an impact including loss of independence and social interaction, decreased quality of life, and 1 in 3 people with AMD actually have depression. So that's quite a big statistic. The prevalence has been found in a European population to be 1.4% at age 70, 5% at age 80, and up to 20% at age 90. So it really does increase with age. As a working group, we've gone through the risk factors that lead to AMD and have grouped things into a strong level of evidence, a moderate level of evidence, and a weaker level of evidence. So I'll just go through those firstly, as we need to be quite cognizant of that as we're considering somebody's risk for AMD. The most obvious one, of course, is older age. So that's the strongest risk factor for AMD. And it's found that the risk of developing AMD increases more than 3-fold in patients over 75 compared to those aged between 65 and 74. The next strong risk factor is family history, and over 34 different genetic loci have currently been identified. And the third strong risk factor is smoking, which is the strongest modifiable risk factor, and it's been shown to at least double the risk of AMD, with a direct correlation between people who currently smoke and the risk of late-stage AMD, and also the number of cigarettes a person has smoked during their life and their risk of late-stage AMD. And smokers on average develop AMD about 5 to 10 years earlier than non-smokers. The moderate risk factors include hypertension, cardiovascular disease, and a high BMI. And they can up to double your risk of late AMD. The weak risk factors are related to diet and lack of exercise, and there has been studies that show diet low in omega-3 fatty acids, vitamins, carotenoid and minerals, as well as a diet high in fats, as well as lack of exercise, do have a weak link to risk of AMD. And although a higher level of evidence is currently lacking, nonetheless, the working group considered it prudent for clinicians to advise patients at risk of AMD of these lifestyle factors. So I'm going to spend a bit of time now talking about classification of AMD. Historically, there's been a big range in classification and different systems used. And so I want to draw your attention to the one that is currently in practice, which is called the Beckman classification system. So a group of experts formed the Beckman Initiative for Macular Research Classification Committee and came up with a classification system that was quite simple. So it really distills things down to early AMD, intermediate AMD, and late stage AMD. But they also spent the time looking at what is normal and what is normal aging changes. So we're going to go through that now. And all of this is actually in a paper that they published in Ophthalmology in 2013 by Ferris et al. So just looking in your screen there, you can see that we have fundus photos on the left, optical coherence tomography scans in the centre, and also fundus autofluorescence or FAF on the right. So in the normal classification, where there's no drusen and no AMD pigmentary abnormalities, we just see a nice pink fundus. The OCT has all the layers correct and accounted for, and nothing seen on the FAF. In normal aging changes, where the circle is there are tiny little druplets, which are actually small drusen. And that term druplet was brought about to try and show that this is actually normal and get away from the term drusen for those who have normal aging changes. But they are in essentially small drusen, which are less than 63 microns. And I'll talk a little bit later on about how we can judge the size. So normal aging changes, druplets, and no pigmentary abnormalities. For early AMD, the classification is medium-sized drusen, so they're drusen that's between 63 and 125 microns, and no pigmentary abnormalities. For intermediate AMD, the classification is, this covers large drusen, which are greater than 125 microns, with or without pigment abnormalities. If it's large drusen, it's intermediate. It also covers medium drusen, which is greater than 63 but less than 125 microns, in addition to pigmentary abnormalities. So intermediate can be either simply large drusen plus pigmentary abnormalities, or medium drusen plus pigmentary abnormalities. And late AMD is classified as two different types, the first of which is geographic atrophy, shown at the bottom here. And geographic atrophy is an area of photoreceptor and RPE loss, which can be seen as an area that's greater than 250 microns and with the choroidal vessels visible in the base, as you can see on the fundus photo. In the OCT scan, you can see the black layer, which is the outer nuclear layer, has disappeared in the centre there, which is corresponding to the region of geographic atrophy. And in the fundus autofluorescence, you see the big black patch, which corresponds to the area of GA. And finally, the other type of late AMD, neovascular AMD, can be seen as hemorrhages. Subretinal fluid and intraretinal fluid are seen there on the OCT scan. And of course, a large neovascular membrane that can also cause a PED or pigment epithelial detachment, such as shown on the bottom there. This group also put together a 5-year risk of progression to late AMD, which is based just on drusen and pigment abnormalities. So the risk of progression, which is worth considering as you're trying to work out who's going to progress to late stage AMD, which is what we're all trying to prevent. So the risk of progression to late AMD for somebody who doesn't have it in either eye at baseline, you assign a risk factor for each eye that has large drusen, each eye with pigment abnormalities, or one factor if both eyes have medium drusen and no large drusen. So for example, somebody who just has one eye with large drusen has a risk factor of 1, and they have a risk of progression of 3% to late AMD within 5 years. Somebody who has large drusen and pigment in both eyes has a risk factor of 4, so they have a risk of progression of 47% to late AMD in 5 years. For somebody that's already had one eye that has late AMD, the risk of the fellow eye progressing, they get 2 risk factors because they've got an eye already with late AMD, and then they get an extra risk factor if they have drusen in the fellow eye and another factor if they have pigment. So somebody that does have drusen and pigment in a fellow eye has a 53% chance of progressing to late AMD in the fellow eye within 5 years. So the symptoms. For early and intermediate AMD, it's usually quite asymptomatic, although sometimes patients can report reduced contrast sensitivity and reduced dark adaptation. So they might just feel that things aren't quite right with their vision, but you put them on the vision chart and at high sensitivity and they seem normal. But for somebody with late AMD, of course, you get the reduced visual acuity with a central visual field defect or blur. You can get the scotoma and distortion on the Amsler grid, and the patients will report difficulties with visual tasks, including activities of daily living and even things like navigating stairs, reading and recognising people. And a final thing to be aware of is people with late stage AMD can actually have visual hallucinations, which is well known as Charles Bonnet syndrome, and can be quite distressing to people. So sometimes people do need referral for counselling. The signs of early and intermediate AMD. So we're just going to go back to those images of the fundus photos again. So for early, which just to remember is medium-sized drusen, 63 to 125 microns. And the clinical pearl here is that you can judge the size of the drusen relative to the central retinal vein width at the disc margin. So that central retinal vein width is 125 microns. So we know that medium drusen is between half to a full vein width. So that image there on the left with the blue circle shows some examples of medium-sized drusen. For intermediate AMD, it's large drusen greater than 125 microns, so that's drusen greater than the width of that vein near the disc margin, plus or minus pigmentary abnormalities, or for intermediate AMD could also be medium drusen between 63 and 125 microns, as long as there's pigment abnormalities as well. And the third thing that can happen in intermediate AMD is plus or minus pigment epithelial detachment, called PED, due to the confluence of large drusen forcing the pigment epithelial layer to rise or elevate. For the late stages of AMD, for geographic atrophy, it's defined as photoreceptor and RPE atrophy within a well-demarcated lesion greater than 250 microns in diameter. So remembering again that that central retinal vein width at the disc margin is 125, so we need to double that. It needs to be at least twice the width of that vein to be classified as GA. And you need to be able to see choroidal vessels visible in the base. For the choroidal neovascular membrane type of late AMD, it's visualised as a well-demarcated grey or green area. There can be macular fluid, both sub or intraretinal, and there can be lipid or hemorrhage, and you can also see a PED, it's pigment epithelial detachment. There's one other sign I want to talk about quickly, and this is non-stage specific, so not specifically linked to early, intermediate or late, and it's actually not unique to AMD. You can see it in patients who actually don't have AMD. However, reticular pseudodrusen, also known as RPD, is associated with an increased risk of progression to late AMD. So if you see it coexisting in an AMD patient, you need to be thinking that this patient is at risk of progression. Now, I'm not going to talk about it too much because Angelica's going to talk about it coming next, but basically it's a yellowish net-like subretinal drusenoid deposit. which is often in the perifoveal region, so not right at the fovea, but in the area surrounding the fovea. And you can see an example shown here on the left, that net-like patterning that's all around the edges of the blood vessels. And in the blown up image, you can see the RPD extending through to the outer nuclear layer, and it can affect photoreceptor integrity and is also associated with retinal gliosis, which is like scarring and changes in the glia and RPE damage. So we just need to remember, if we do see this net-like changes then in people with AMD, then they have a higher risk of progression to late stage. The optometric assessment protocol. So most of this you guys will be using very regularly. History, of course. We want to screen for new symptoms suggestive of AMD. We need to establish the risk factors and include family history, smoking history, and any documentation of nutritional supplements, as well as the driving status. The visual acuity needs to be measured, including near acuity, and we also need to do a dilated fundus exam, including a stereoscopic biomicroscopy evaluation of the macula. And we recommend this at least annually for those with signs or symptoms of AMD. And we can consider the patient's risk profile as well to help determine if the patient requires a DFE. The AMSLA grid can be used both in the clinic and also as a home monitoring tool, and it's been around for a long time, so you'll all know about it. Presenting the grid does show areas of scotoma or distortion at the macula. Two other quite useful tests that the group wanted to raise with optometrists is contrast sensitivity and the photostress test. So because patients often have issues at lower contrast sensitivity as an earlier symptom, by measuring the contrast sensitivity, you can actually tell a patient, yes, although your vision acuity at high contrast is good, we do see a loss in your low contrast, which matches with the signs that we're seeing of drusen and potentially pigment at the macula. And the other one is the photostress test, where you can hold your light up to the eye, so your ophthalmoscope light or your transilluminator, and hold it there for 10 seconds, and then you're waiting to see the person's recovery of reading to within a line of their best corrected visual acuity. And if they have a prolonged recovery time, then it indicates macular disease. So recommended ocular imaging is both a colour fundus photo, which many of you will have, and also the OCT if possible. So on colour fundus photo, we mostly use it for looking at the drusen and the pigment abnormalities, and we can monitor this over time by taking the photos. And it's also good for looking for CNV and GA. The OCT, and I'm just flagging that there's going to be more detail about looking at OCT and AMD in Angelica's talk, but can be very useful for looking at active neovascular AMD, as well as drusen and pigment changes, and particularly these days because there's been a number of prognostic biomarkers that have been found with OCT that are very useful for detecting or predicting who's going to progress to late stages. So again, Angelica's going to give more detail, but I just want to flag to you that reticular pseudodrusen, that we've already talked a little bit about, as well as hyperreflective foci, which are these little white dots that appear. There's one in the bottom image there on your screen now. And the third one is nascent geographic atrophy, where you start to get these wedge defects appearing through the outer nuclear layer of the photoreceptor layer. So those three things are quite important to help us predict who's at risk of progression. So keep those in mind. There's additional multimodal imaging that can be used, including fundus autofluorescence that we've already been having a look at some of those images, and near-infrared imaging. The FAF gives a better demarcation of the GA than a photo, and you can see that in the image shown on the screen. And it also shows the reticular pseudodrusen, the RPDs, more easily than in a photo. The near-infrared imaging also shows the geographic atrophy, but differently to the FAF, it shows it as a bright area due to the reflection off the sclera. and it also shows the reticular pseudodrusen more easily than in a photo, so they can be both quite useful. And the final form of imaging that's recently become available is the OCT angiography, or OCT-A, which can be useful to image retinal and superficial choroidal vasculature and blood flow. And this is an image here that's come from Professor Robin Guymer and as part of the Zeiss ARI network. And all the images actually in the guide in the presentation have been kindly provided by Professor Guymer. And so this is just showing that you can look at these networks of choroidal neovascular membrane with OCT-A. However, it does not detect vessel leakage, so there's still a place for fluorescein angiography. I'm going to run quite quickly through the differential diagnoses. I've put the list there along with a matching image going from left to right on your screen. So the first three, central serous chorioretinopathy and adult onset vitelliform dystrophy and Best disease, have macular lesions, but it's not drusen or pigmentary changes. The Stargardt's disease, you can see the choroidal vasculature similar to GA, but again, you don't get the drusen and the pigmentary changes, and this generally onsets a lot earlier than AMD. And the next one, the familial dominant drusen, you do get drusen, similar to AMD, but it's over the whole retina, not just isolated to the macular area. And the last one, epiretinal membrane at the macula, you get the thickening of the inner limiting membrane and contraction of that membrane, but you don't get the drusen. So on to management, which is what everyone wants to know, I'm sure. So for early AMD, we have recommended a review at least every 12 months. It doesn't require referral to an ophthalmologist, but it is good to discuss healthy diet and lifestyle. And if you have an OCT, a baseline OCT is a great thing to do to help with monitoring in the future. For intermediate AMD, these are the people that we need to watch a bit closer because they're at higher risk of progression to late stages. And we recommend review every 6 to 12 months, just depending on what that person's risk factors are. So if they are people that you've found any of those prognostic biomarkers, such as the RPD, the nascent geographic atrophy, or the hyperreflective foci, then you should be considering an earlier review closer to every 6 months rather than 12 months. And people with those as well, it's great if we can get an OCT or multimodal imaging. It's good to discuss healthy diet and lifestyle options with these patients. And the ARIDS2 publication has also indicated that daily use of vitamin supplements is an option for these patients too, to help reduce risk of progression. And the final thing to point out is OCT is advised if new symptoms have developed or if there's any suspicion that signs of neovascular AMD may be present. In this case, we recommend referring to an ophthalmologist or an optometry colleague if needed. Just to touch on those evidence-based lifestyle factors again. So these are the ones that we've talked about already through the risks at the start. So smoking, which is the strongest modifiable risk factor. So given the known correlation with smoking status and risk of AMD progression, it is recommended that optometrists do advise all patients that smoke to try to quit or reduce their smoking. Diet and lifestyle. So it's also good to advise patients a diet rich in green leafy vegetables, fish and antioxidants should be encouraged. And also that systemic conditions including hypertension, heart disease and obesity are also risk factors for progression to late AMD. As I've already mentioned, the ARIDS2 formulation has been found to help slow progression to late AMD in people with intermediate AMD only. So the management of late AMD, the geographic atrophy type, at the moment there's no regulatory approved treatments, so we recommend monitoring 6 to 12 monthly and to consider the person's driving status. We also need to consider the progression risk to neovascular AMD and provide a home AMSLA grid for monitoring. We talked to them about the modifiable lifestyle factors and of course provide any low vision care that's required. For management of the neovascular form of late AMD, this is the red flag for referring to the ophthalmologist within 1 week of suspected new onset neovascular membrane. And from the history, this can be reported as an onset of vision loss, distortion, or a missing patch or blur in the central vision within the last 3 months. The signs include seeing the neovascular membrane, the grey-green patch, or macular fluid, both sub or intraretinal fluid, and macular hemorrhage. And of course, telemedicine these days is now available as well for people to use. Once the patient is referred to the ophthalmologist will consider anti-VEGF intravitreal injections as the mainstream treatment. There's 3 options available: Lucentis, Eylea or Avastin, and the ophthalmologist can use either a fixed monthly interval or a treat and extend protocol. I'm just going to run through a couple of quick scenarios now just to help recap and consolidate what we've been through. So the first scenario is a patient who's 65, female, a smoker, attends with symptoms of difficulty reading in dim light, trouble adapting to light levels when going into a cinema, and trouble with glare from oncoming headlights. We find that they have mild hyperopia, presbyopia, but the Amsler grid is normal, the IOP and cup to disc assessment is normal. But we do find when assessing the macula that they have both medium and large drusen, as well as reticular pseudodrusen in both eyes. So this is an example of what it might look like in this patient. In the colour fundus photo, you can see quite clearly the large drusen. In the fundus autofluorescence and the near infrared, you can see the reticular pseudodrusen, that net-like pattern in the perifoveal region. And in the OCT as well, you can see both drusen and RPDs that extend into the outer nuclear layer. So how do we classify this patient? Hopefully you have all said they have intermediate AMD, and we can advise this patient that because they have large drusen and no pigmentary changes, that they have a risk of progression to late AMD in 5 years of 12%. And we would advise regarding smoking cessation, diet, lifestyle, and offer them potentially AREDS supplements. And we would give them the home Amsler, advise that there is a risk of progression, so to be watching the home Amsler and to call if their vision changes at all. And we would consider a 6-month review in this case because they do have RPD, the reticular pseudodrusen, that puts them at higher risk of progression to late stage of AMD. So hopefully that all makes sense. On to scenario 2. So this is an 80-year-old male non-smoker, last seen 12 months ago, and we knew at that appointment that they did have intermediate AMD. They attend this time with symptoms of a grey patch in the centre of the left eye for the past 2 weeks. We find they have presbyopia, pseudophakia. On Amsler grid, their right eye is fine, but the left shows some wavy lines and a grey region at the fixation point. The IOP and disc evaluation is normal, but we can see the large drusen and the pigmentary changes at the macula in both eyes. And we can see with the OCT scan that there is subretinal fluid noted at the fovea. And so you can see that black region there highlighted with the measuring bar, lifting up the retina, which is the subretinal fluid. So what do we do? This is a suspected new onset choroidal neovascular membrane, so suspected late AMD, and we need to send this to the ophthalmologist within 1 week as an urgent referral. The ophthalmologist will do OCTA if possible and commence treatment with anti-VEGF intravitreal injections, or else closely monitor. Some ophthalmologists, if they see only fluid, they'll have a look at the fluorescein angiogram and OCTA and decide that they may closely monitor rather than starting anti-VEGF injections immediately, but that is a consideration for the ophthalmologist. So I'd just like to talk about some future directions. Things are changing a lot in the AMD assessment and management space at the moment, but we do know that early detection and treatment is vital for the best patient outcomes. And I should have mentioned that the best outcomes from the neovascular membrane event and anti-VEGF treatment occurs if the VA is lower when they first start treatment. So people that haven't realised that they have a problem and report very late with a worse VA have much worse final outcomes after treatment. So it's really important that we get early detection and early onset treatment. And optometrists have a major role to play in this regard and also in monitoring. So there's been a lot of work because the AMSLA grid has been around for a long time, and it's not always been very super helpful in helping detect up all the early cases of people progressing to late AMD. So there's been a lot of work overseas with people developing the 4C home device, which is available in the US, and also an app called My Vision Track, which is available overseas and can be used in monitoring AMD. And in the future, as this becomes more available, optometrists will be involved more in monitoring the monitoring. There's also likely to be new AMD treatments in the near future, with a lot of clinical trials currently in progress for geographic atrophy. And so as a treatment becomes commercially available, we will need to make sure that we're referring to get the patients get the treatment when they need it. And there's also a lot of opportunities for patients to be involved in research because there's a number of trials happening now. Two websites in particular to point you to. The clinicaltrials.gov website lists all the clinical trials worldwide and where they're operating from, including in Australia. And there's an Australia-wide clinical trials website register through the CIRA website. So if you go to the CIRA web address, there's a big purple button that says Clinical Trials Website Register, and patients can actually self-register and even upload the images so that the people running the trials can see who's interested in being involved. So that's all from me, and thank you very much for your attention. I hope you enjoy using the guide, and it will of course be reviewed in due course. Happy to take questions
Thank you,
a bit later.
That was fantastic, and it looks like the working group really didn't leave any stone unturned. You've taken everything from start to end of the journey, the patient journey, and really tried to make sure that...
We've had a diverse group,
Yep.
and it's been great working with the other members of the team
Yep.
to produce this guide that'll hopefully be very helpful
Absolutely.
to optometrists.
Yeah, and it's quite a useful, handy sort of guide. And as we mentioned, the guide is available at optometry.org.au. It's exclusive for members. You can see it on your screen there, 2019 Clinical Practice Guide. We encourage you all to download that, have a handy soft or hard copy next to you as you're practicing. The other thing I found quite interesting was about the sort of the lifestyle changes, particularly around smoking. There's a lot of evidence, I know, sort of around that, and certainly I think optometrists play a significant role when it comes to smoking cessation, probably a bigger role than we do play in encouraging patients to change their lifestyle around smoking and those sort of things.
That's right. Well, a lot of patients know that smoking is not good, but they don't necessarily know that it can be contributing to their AMD getting worse.
Yeah,
so
absolutely.
It's up to us to help to
start
educate.
that health promotion and those messages. Thank you again, Carla. We're going to come back to you for questions after Angelica's talk. Ladies and gentlemen, we'll be back in a minute or two. We're just going to take a short break and get Angelica in the hot seat to talk to us a little bit more about AMD imaging, present and future imaging. Stay tuned. Welcome back, everyone, and thank you for joining us on this AMD webcast that we're presenting live from Redback Studios in Melbourne. Now, imaging and ocular imaging has become very topical and very sort of, front of mind for a lot of eye disease and detection, and we're aware of that. And particularly in AMD, we've looked at obviously different modes of imaging and things that have happened in the past and also present and future AMD. You know, Optometry Australia has been embarking on this Futures 2040 project and imaging again was front and centre there. Tonight we have Dr. Angelica Lee talking to us about AMD imaging, past, present and future. Dr. Lee is a clinician, a lead clinician at the Centre for Eye Health in New South Wales. Her PhD thesis was titled Multimodal Evaluation of Macular Structure and Function in AMD, a mouthful. And she has a number of peer-reviewed papers published in leading journals. Angelica is an enthusiastic educator, teacher and clinician. She's presented at both Australian and international conferences, including ARVO and the American Academy of Optometry Annual Conference, and it gives me great pleasure this evening to introduce Angelica. Thanks, Angelica. Take it away.
Thanks, Simon. So science and technology revolutionise our lives, but memory, tradition and myth frame our response. I stumbled upon that quote last night and I thought it was really apt because for me, ocular imaging is really an enabler. It forms the basis for clinical collaboration, research, teaching and outpatient care. For me over the years, it's really supercharged my understanding of ocular disease. It's enhanced my medical record and has been really invaluable for early detection and for the closer follow-up of our cases. So in tonight's talk, I've structured it around some of the major developments in eye imaging. I'll be looking at the applications to AMD, provide my top pick for the future, and then if time allows, I'll wrap up with a short case study. So you probably guessed it, the first breakthrough moment in ocular imaging was really the retinal camera. Now, it was much earlier in 1886 that the first ever recordings of the human fundus actually occurred in vivo. But it was not until 1926 that none other than the Zeiss camera company brought the very first retinal camera to market. It boasted a very cute 10-degree field of view and required manual exposure. So the reason I start with fundus photography is because it forms that historical standard we all are really comfortable with. The images that we get correspond really well with fundoscopy, which makes it super intuitive to us as clinicians. It comes in both monoscopic or stereoscopic variations, and the images we take can be taken through dilated or undilated pupils. Some of the disadvantages of fundus photography, though, are that the images we get can be of a relatively low contrast, they can be degraded by media opacities like cataract, and the field of view is often very limited. Take, for example, the one we've got pictured here, which extends to about 45 degrees. This slide here showcases, though, how good retinal photography really is at capturing the full spectrum of clinical signs in AMD. And Carl has already gone through this in wonderful detail for us, so I won't labour the points. But you can see in the first column on the left a case of early AMD with medium drusen. In the second column, I've got a case of intermediate AMD with large drusen, well, small varying all the way up to large, I should add, and also drusen at various sizes. You'll note that some look shinier or more refractile than others, and those are calcified drusen. There are also pigmentary abnormalities in that same intermediate AMD case. In the third case, we've got a case of advanced AMD or geographic atrophy. And as described, so we've got this really well demarcated area where there's increased visibility into the choroid. Final case on the right is an instance of choroidal neovascularization where we can see that classic telling sign of the grey-green lesion. Now I challenge you at home if you can tell which of those maculas is actually edematous or swollen. And it would be the one on the right by intuition. We would assume that the advanced choroidal neovascularization case actually has fluid under there lifting it up. But of course you can't tell that from the flat photo. And that provides us with a nice segue into why stereoscopic fundus photography is just so valuable. So if you've got a stereo viewer handy or a loose base art prisms, I presume you don't, but you would be able to appreciate that this eye actually has neovascular AMD and that the macula is indeed swollen. Other ways that we can tell location or try to guess what additional signs are there would be using filters. So the red filtered image on photography allows us to see into the choroid. The green filtered image highlights retinal vasculature really well and the retinal details, and we use it probably the most when we're looking at the RNFL. There's also the blue filtered image, which provides us with vitreomacular interface or more superficial type details. Moving on to the next invention, this is the one of fluorescein angiography, which was developed in 1961. And now this one we know it well as an invasive intravenous mode of imaging, I should say. It requires an injection of fluorescein, and the images we get are sequential photos. It gives us a way of studying the choroidal and retinal blood flow, and it really forms our gold standard for diagnosing choroidal neovascularization, which is why we'll often get some detailed intricate letters from our ophthalmological colleagues describing both the location and type of CNV in detail. The classical textbook type indications for fluorescein angiography include any conditions or cases where you suspect a breakdown in the blood-retinal barrier, be it, for example, neovascular AMD or diabetic retinopathy. But what's really interesting is that these indications are certainly evolving thanks to the advent of OCT. But what I can't stress enough is, of course, that fluorescein angiography is outside of the scope of optometry because of the risk of anaphylaxis and possibly even death. Now, a short 8 years later, indocyanine green was applied to the eye. And this technique overlaps a lot with fluorescein angiography. Because it uses an infrared excitation and because the molecule is a little bit larger, we can actually visualize through to the choroid. And the indications for performing indocyanine green would be for any kind of pachychoroid or thick choroid associated condition, like polypoidal choroidal vasculopathy or chronic central serous choroidretinopathy, which can oftentimes mimic exudative AMD. Now, in 1991, the first OCT images were published in the scientific literature, and of course that changed everything. It's a technique that's near and dear to our hearts. Over 50% of us are using it in the routine assessment of AMD cases, and it uses near-infrared light and based on a principle of low coherence interferometry. What we get is this wonderful kind of high-resolution way of imaging the retinal microarchitecture. Now, the instruments of yesteryear were time domain, but the more current models are either spectral domain or swept source. And if you have a spectral domain model and want to see more into the choroid, then there's also the enhanced depth imaging option. In short, the way OCT works is that we get an A scan, in other words, a reflectivity profile in the axial direction. Multiple adjacent A scans can then be compiled and summed to form a B scan, and that's the cross-sectional view that's analogous to kind of an ultrasound, like an optical biopsy. The C scan view is provided by the sum of multiple B scans, and that's really an en face or front-on type view. So as applied to the macula or to AMD, we often think of, the first report we probably think of with OCT would be the macular thickness plot. And so what you're seeing pictured here is the report that comes direct from the Cirrus OCT. And that's a really good tool for visualizing or getting an idea of the overall thickness, kind of broken down across the various subfields. But probably what's lesser used would be the ability of OCT to actually segment out each of the individual layers. So this is the view that we get through the Heidelberg Spectralis OCT. And now thinking about AMD, it's primarily an RPE disorder with associated outer retinal changes. So I actually now have the ability, and this is commercially available, to segment out the various layers of the outer retina. And then I can analyze the thickness and integrity of those. So take here, for example, the Cirrus OCT Advanced RP Analysis. That gives us a way of automatically identifying any areas of geographic atrophy. In this case, there aren't any present, but it also gives us an ability to quantify the overall drusen load. And that can be really powerful when we're monitoring our cases. The same case that you saw pictured earlier with the neovascular AMD, OCT makes it plain as day that there is in fact subretinal fluid and that this retina is in fact lifted off. So this is a nice one. You're seeing the subretinal fluid as well as some intraretinal cystic spaces and some associated hyperreflective foci. Now, a form of OCT that I think is underutilized would be the en face or that C-scan type modality that I mentioned earlier. So in short, the way en face OCT works is if you look at the B scan, so that bottom panel, there you can see that there are these purple lines on the B scan. Basically, the reflectivity contained between those two segmentation lines is summed to provide us with that en face front-on view. So toggled right in this intermediate AMD case, I can get a really quick snapshot view of the overall drusen load. In this case, this is a case of geographic atrophy or advanced AMD, where unfortunately the retinal photo is overexposed. So it makes it really hard for me to tell where the GA starts or ends. But again, play my cards right, use on-fast OCT in the right way, and I can get a really quick view of where the full extent of that GA is, the fact that it's involving just the temporal macula and it's sparing the fovea center, which might explain why the patient's got good visual acuity. Third case, a different eye again. This one now has neovascular AMD, again that telling grey-green lesion in the inferior macula. I've toggled the on-fast OCT to segment out just the ellipsoid band, and now you can see that there is in fact a small pocket of subretinal fluid as well in the nasal macula that's associated with that neovascular network. Now OCT for refined phenotyping, that's a bit of a mouthful, I'll say. But in short, if we think about the kinds of cases that we as optometrists are most likely to encounter, that would be kind of your early or intermediate substages. And really, the problem when we see those cases is that they have anywhere between a 3 to 50% risk of progression to advanced AMD over the coming 5 years. So it's really hard for us to decide which of those cases we need to monitor more closely and which we can just let go. Well, let go being probably not a good choice of words. We're still seeing them every 12 months. But the idea here being that we need some tools or some extra support to identify which of the cases are at higher risk, in other words. So over the next 6 slides, I'll be walking you through, as Carla's introduced, those prognostic biomarkers, which tell me that my patient or that eye is at a higher risk of progression. So the first would be hyperreflective foci. And these really appear as those white dots in the outer retina. They occasionally migrate inward, but they often correspond with pigmentary abnormalities on retinal photography. But the reason that they're important is that they can, on rare occasions, actually represent a preclinical sign of choroidal neovascularization. So you could have the potential of actually being able to capture or catch your neovascular AMD cases earlier. Here, subretinal drusenoid deposits, so the notorious reticular pseudodrusen that as they appear on the retinal photo, you can see that they're clustered, in this case in the superior macula, and on OCT, on the B scan themselves, those reticular pseudodrusen are kind of easier to detect, I would say, because of their subretinal location. They're actually sitting above the RPE rather than below, where normal drusen would. Sub-RP hyperreflective columns. Now you can see these present really as a kind of a thinning or a breakdown in the RPE, which causes this kind of slither of posterior hypertransmission. And you can see that this would be a really early, you can see it's not a stretch to see how this could be a warning sign or could later go on to develop into geographic atrophy. Nascent geographic atrophy has been mentioned already, and it was recently renamed incomplete RPE and outer retinal atrophy. And so what this appears as is really a hyperreflective wedge with associated collapse or subsidence of the outer plexiform layer. There's also a thinning or attenuation of the RP, and that tends to cause trace posterior hypertransmission. And so again, these are often a precursory sign to full GA developing later. Small pockets of subretinal fluid should also raise your suspicion or your concerns that the patient's eye might progress to advanced states. So anytime you see it, I would be highly suspect of CNV. And now this last sign is probably a bit more equivocal. Jury's probably still out on it. But what's interesting is that in some eyes, if you look really closely at the reflectivity of the drusen, they can actually present in different ways. So on the left, we've got a more hyperreflective variation of drusen. In the middle instance, we've got some L-type or low reflectivity drusen, and on the right, a C-type or conical variation with actual foci within it. Now, in 1995, the very first description of autofluorescence imaging with a confocal scanning laser emerged, and it was marketed by Heidelberger's kind of blue peak technology. And I think that description is really apt because the way it works is that it uses a blue light form of excitation to visualize lipofuscin in the RPE. And now you can think of lipofuscin really as a biomarker of RPE distress. There are other ways of getting an autofluorescence image, for example, using green light on the Optos cameras. Some more research type instruments use near infrared, and there's also a quantitative fundus autofluorescence modality available too. Thinking about how FAF can be applied to intermediate AMD in particular, there are really three patterns to be wary of. The first would be the patchy pattern, which you see on the left, and they tend to correspond with large drusen. The middle one, we're seeing a linear pattern, which tends to correspond with pigmentary abnormalities. And on the right, we're seeing this kind of clustered network type depositing appearance, which tends to correspond with the reticular pseudodrusen. So it's those three patterns, the patchy, linear, and reticular, in your intermediate AMD cases, which may actually carry a high risk of progressing. Mentioned already, geographic atrophy can be really hard to detect using fundoscopy or photography alone, but using fundus autofluorescence, the beauty is that it's such a high contrast instrument that we can see the geographic atrophy areas plain as day. They're very well demarcated and they're very hypofluorescent, as you're seeing here. More interesting still, if you actually study what's described as the junctional area, or in other words, the areas surrounding the areas of geographic atrophy, once again, we might be able to predict which eyes actually go on to progress quicker. And now this is a bit of a complex flowchart, but the two kind of key patterns that you want to be aware of are if in your geographic atrophy cases you see a zone or a distinct band of surrounding hyperfluorescence, or if there's a diffuse trickling pattern like the one that we're seeing up the top. So those two subtypes, again, can be at a higher risk of progression. Fundus autofluorescence imaging can also be really helpful for distinguishing AMD from mimicking disorders. So this case was referred to the Centre for Eye Health suspected of AMD. And this is the ultra-wide field image that we're seeing here. And so you can see why AMD was suspected. There appear to be these yellow deposits affecting the macula, but also scattered beyond. Apply autofluorescence imaging, and what you can see that's striking here is, first of all, there's sparing around the optic disc, so peripapillary sparing. Those deposits now suddenly look a lot more fleck-like, and that's because this is a case of fundus flavomaculatus. Talking about scanning laser ophthalmoscopy, it also can be applied using near-infrared wavelengths, in which case it would be described as infrared imaging. That uses a wavelength anywhere between 750 and 840 nanometers. And the beautiful thing about using an infrared wavelength is that the pupil doesn't constrict, and it's very well tolerated by the patient. So it's minimally interfered by media opacities as well as macular pigment. Here's an example of a case of advanced AMD with geographic atrophy. In this case, it's multilobular and spares the fovea. And you can see quite clearly that the infrared imaging, the high contrast once again of that scanning laser, helps to really make those areas very distinct. Here's a case of reticular macular disease. So reticular pseudodrusen depositing diffusely throughout the macula. And on the infrared image, you can see the distinct target appearance on some of those reticular pseudodrusen. You're also seeing some hyperreflective spots. And so once again, to stress, if you're not already looking out for reticular pseudodrusen, I really encourage you to do so, because they do carry up to that 6-fold higher risk of progression. They occur anywhere between 9 to 36% of our AMD patients' eyes. And as I touched on earlier, sometimes it's nice to combine the infrared imaging with the OCT, because on the OCT cross-sectional or B-scan type image, they appear in a subretinal location. What's interesting is that reticular pseudodrusen carries such a high association with advanced AMD that it's led some authors to speculate that if you have an eye with advanced AMD and you don't have the reticular pseudodrusen, you might want to reconsider the diagnosis. Now in 2005, the AREDS grading scales were released, and this was really a big game-changing moment. So I know the topic of my talk is really imaging, but I think it felt incomplete without adding this. So the AREDS classification, or the AREDS grading, really formed the basis of the current classification which we all use today, the Beckman Initiative. In that grading scale, it's important to note that AMD is classified using clinical examination or evaluation of fundus photos. And as touched on already, AMD is really a kind of a spectrum disorder that includes signs ranging all the way from drusen up to GA and CNV. The authors of the Beckman Initiative, or the consensus panel of experts, were also very careful to say that it's important to avoid terms like dry and wet. Now in 2006, OCT angiography was developed. And so this type of modality, it is now available commercially. It provides us with a non-invasive way of really studying the choroidal and retinal circulation. And I think it's going to be a game changer for optometry. Unfortunately though, some of the limitations is that it doesn't allow us to visualize leakage. The scans take longer than your typical OCT, and the field of view can be limited. There's also a bit of a steeper learning curve. There are a lot of artifacts that you need to train yourself to get used to. And the variations, it comes in both a spectral domain or swept source OCT models. So if I can direct your attention to the images now on the right, this is the normal OCTA appearance that we get in a healthy macula. So we generally look at, in general terms, and teaching you how to interpret OCTA is a whole another lecture in itself. But in general terms, this is what you would expect to see in a healthy eye. So you've got the superficial vascular plexus, the deep plexus here, the avascular plexus, which is where the photoreceptors sit, so there should not be any vessels there at all in a healthy eye, and then the choriocapillaris. So keeping that in mind, I think that provides us with a nice foundation for seeing now how OCTA can change optometric practice. So this is a case we've seen at the centre, a case of a 66-year-old Caucasian male who was treated for macular degeneration in his right eye only some 4 years ago. Visual acuity is down to counting fingers at 50 centimetres, and you can see in the retinal photograph why. He's got a large disciform scar, but what's concerning is that when he saw us, his acuity was 619 plus 2 in the left eye. He's got AMSA distortions in both eyes, and contrast sensitivity is reduced in the left eye. Now here's the OCTA image, and what's striking in this eye is that you're getting clear evidence of the mature neovascular trunk that's contributed to that disciform scar. But of course, it's the left eye that worries me. Looking at what's scary as well is looking at the fundus photo alone, there's not that much to see. Use the infrared image though, and you can see now that there are deposits diffusely scattered throughout the macula. Apply OCTA, and now we're starting to see the semblance of a new vessel forming. There's also the associated subretinal fluid, which is quite telling. So this patient has neovascular AMD now in the left eye, which needs 1 week referral to an ophthalmologist. So that brings me to present day, in which of course we've released this clinical practice guide, which has brought us here this evening. And so, as Carla's already mentioned, we came to the consensus opinion that it's colour fundus photography and OCT, which are really the recommended core imaging modalities in AMD. VAF, near-infrared and OCTA form additional modalities that can help with your practice. But one of the key points that we really wanted to stress in that guide was that multimodal imaging is king. And what I mean by that is multimodal imaging, which is really the combined application of more than one modality. And that includes things, anytime you kind of interpret an OCT in combination with an on-FUS fundus reference image, that's multimodal imaging. And the reason that we do it is kind of to cover all bases, I would say. The beauty of using more than one instrument is that you can make up for the weaknesses of one using the strengths of another. So take, for example, reticular pseudodrusen. It may be new to a lot of members out there. So I suppose so. The point being that if we use multimodal imaging, we're more easily able to detect their presence. So on fundoscopy, they tend to appear reticular or networked, kind of as a cluster of small yellow-white lesions. On infrared, I touched on already how they tend to co-localize with those hyper-reflective spots. Alternatively, they can have a target appearance. The image you see on the right is actually a blue filtered retinal photo where you're seeing those hyper-reflective reticular pseudodrusen again. So I get this question a lot, what's going to be the next major breakthrough eye imaging device? And I hope kind of from all that I've described today that you'll agree that I don't think we need another breakthrough device. We don't need another OCT to change the game. I think what we really need is a way of applying and using the information we have better. So to that end, I think the main game-changing innovation will be what's described in the literature as computerized clinical decision support systems. And those can be kind of multi-element. It could be made up of multiple parts. Take, for example, a structured medical record keeping. So what you see on the right is actually a form of is a variation of the record chart that we've designed to use at the centre for all of our AMD cases. And what that provides is a nice kind of point of care, handy way of kind of reminding ourselves what questions to ask the patients, what signs to look out for, what management strategies to apply. In the same type of system, we might also be provided with diagnostic assistance, be it through automated image analysis techniques or even through machine learning and artificial intelligence type algorithms. So pictured here, you're seeing some of the work from my PhD thesis, where we actually were able to combine multimodal imaging results and present the clinician with a classified image. On the bottom, we've got depictions of what machine learning is capable of doing. And really, again, the point being to help us with our diagnosis, help be certainly more accurate and certainly also more efficient. So to wrap it all up, just to tie this all together, I'm going to end with this case study here, which I've entitled AMD Through the Ages. And what I want you to think about in the back of your minds is that one of the eyes I'll be presenting has late AMD, whereas the other has intermediate AMD. See if you can pick which is which. So it's the case of a 72-year-old Caucasian female who's referred to the centre with a diagnosis of age-related maculopathy. She had a history of ophthalmological care and was discharged 1 year ago. She had cataract surgery performed on both eyes in 1997, at which point she was diagnosed first with AMD. She's got heart disease, high blood pressure and pre-diabetes, so is taking a cocktail of medications. There's a family history of macular degeneration in her mother, as well as diabetes. Entrance testing showed a bit of low myopia in both eyes. Acuities were at 6.6, and the grid was clear, but Mars contrast sensitivity was reduced. And so starting with our historical standard of retinal photography, you can see probably the primary clinical sign jumping out would be the evidence of large drusen in both eyes. The filtered photos provide us with a kind of a nicer, higher contrast way of looking at those drusen. And you can see that they're more confluent. There's a higher drusen load in the left eye compared to the right. Running an OCT through it, you can see in this scan here from the right eye, there are hyperreflective foci. There's also an area of nascent geographic atrophy. You'll remember I described that as the hyperreflective wedge with collapse of the outer plexiform layer and some trace hypertransmission into the choroid. Now contrast this slice to the last one, you can see that the posterior hypertransmission is much more distinct. In other words, we're getting more signal out into the choroid. So this is an area of complete RP and outer retinal atrophy. In other words, it's an area of geographic atrophy in this right eye. Using the OCT on the left eye, there are hyperreflective foci, as well as a sub-RP hyperreflective column. Applying autofluorescence, now that we know that there's advanced AMD or geographic atrophy in the right eye, you can see the fundus autofluorescence also highlights it really well. There's that distinct, well-demarcated hypofluorescent area, and that's in the central macular right eye. In the left eye, you remember now they've got intermediate AMD, and there are those three patterns we're looking for: patchy, linear, or reticular. And I would describe the hyperfluorescent signal in the temporal macula as linear, corresponding with the fundus appearance. On the infrared, there's reticular pseudodrusen. It's a little bit hard to see in the slides here, but particularly in the left eye, you might be able to appreciate it. For example, just temporal of the optic disc, and as well in the nasal macula. Sorry, I don't have a pointer, otherwise I'd point them out. Using the ARIDS, and I should say the Beckman Initiative, the most recent clinical classification scale, we can now again, because there's geographic atrophy in the right eye, classify that as advanced AMD, whereas in the left, there's no evidence of GA, no evidence of choroidal neovascularization yet, so they have intermediate AMD in the left eye. Using OCTA, I can say with certainty that there are no new vessels. And so it's really the sum of all imaging that's allowed me to confidently conclude that the patient has late AMD in the right eye, intermediate AMD in the left eye, and because of all those additional biomarkers I spotted on OCT, they're at a high risk of progression. So we should be reviewing them somewhat closely, I would say in 6 months, and then the normal rules apply: diet and lifestyle advice, testing relatives, AMSA grid, and nutritional supplementation. So that brings me to the end of my talk. I hope you found it useful. I hope you've come out on this other side. I know I've given you a lot of information, but a little bit wiser about some of the strengths and some of the weaknesses of ocular imaging. And if, of course, you want more information, please click online onto the Optometry Australia Clinical Practice Guide. On our website as well, we've got a whole lot of additional information, and I can't recommend enough our friends at the AMD Foundation Australia if you need any more support with your colleagues, with your patients, I should say. Thank you. Thanks,
Angelica. And yeah, we sort of got through that in a fairly good time. So we've got a few minutes for questions now, which is good. If you've attended a few of these webcasts before, you've probably heard me say this, but there is no way I'm going to be able to get through all the questions that have come through this evening. So we've been bombarded by questions for both Angelica and Carla around the different areas that they've covered. So let's get straight into it. While we've got you on a roll, Angelica, we'll keep you going. Somebody's asking, can you tell the difference between reticular drusen and normal drusen just by looking at the fundus photos?
It's not easy, so Carla can probably back me up here as well, but I would say that reticular pseudodrusen, they're more often in the superior outer macula. They tend to be slightly whiter, and they're certainly more clustered, so they'll certainly group together, I would say.
That's right. I mean, that sort of net-like appearance that really does become more obvious once you look at FAF or NIR imaging, but on the fundus photo, it is more of often a net-like, and yeah.
Okay. A couple of people, actually more than a few people have asked about the photo stress test that you've mentioned in your talk, Carla.
Yeah.
Sort of the predominant, I think, basis of the question is around sort of how do we define a prolonged recovery time when it comes to the photo stress?
So the recommendation is to hold the light up to the eye for about 10 seconds, and then you're timing the recovery time for the person to get back to within one line of their best corrected visual acuity. A normal recovery time is 50 to 60 seconds, and anything over about a minute and a half up to 5 minutes is a prolonged recovery time and indicates macular problems.
Okay, thank you. Look, Carla, while we've got you, there's another question specifically around assessment of drusen and pigmentary changes. And really the clinicians want to know how far out from the fovea should they be looking in terms of sort of assessing for drusen and pigmentary changes?
Yeah. So you're looking within the macular region, primarily within 2 disc diameters of the fovea.
Okay. That's an easy one to put in the back of the mind. Angelica, you may have covered this, but just for those that have, the viewers that have asked the question, the origin of the reticular pseudodrusen, is it thought to be the same pathophysiology as the normal sub-RPE drusen?
So reticular pseudodrusen, I mentioned how they have a distinctly subretinal location. So pathophysiology, I believe the jury's still out, but the fact that they're occupying different locations in the retina rather than, as I said, subretinal rather than sub-RPE, suggests that they may have a different origin. And certainly it's the reticular pseudodrusen that confer that additional risk on top of if a patient has already large drusen there.
Excellent. Another question for anyone who'd like to answer, the floor is open. The 2RT laser, will that be implemented into ophthalmology clinics in the near future?
So I work within Professor Geimer's unit at the Centre for Eye Research Australia, and she has been conducting the lead study over the past 5 years or so, which has been looking at the 2RT laser in people with intermediate AMD and whether it slows progression to late AMD. And the findings were published last year, and although overall there wasn't a significant outcome with the people that had the laser versus the people that didn't, it was found that in different groups that some subtypes had it potentially worked better than in other subtypes. So there's more studies ongoing at this stage before it's going to be available.
Okay, so stay tuned.
That's right.
Indeed, thank you. Look, another one about pseudodrusen seems to be a bit popular this evening. So if pseudodrusen is sort of high risk and they're mostly smaller, and they don't fit into the intermediate category, do you suggest advising supplements at this stage? Because they don't seem to be sort of assessed in any classification system. So the question is around pseudodrusen and supplements.
I would, so I would say that the original ARIDS 2 and ARIDS studies don't provide us with the evidence to support it. So I would caution against starting a patient with just reticular pseudodrusen with supplements if they don't have any other signs of, say, intermediate AMD. Yeah.
Okay, one last one before we take a break before our last speaker. Someone's I guess just wanted to get a little bit of clarification about when you would refer PED.
So PED can be just a confluence of large drusen within intermediate AMD, and so within the intermediate AMD category, the guideline is to watch and review every 6 to 12 months. But if it's recurring because of neovascular membrane, then that's our signal that we need to have urgent referral within a week.
There you go. So either watch and wait or urgent referral within a week.
So you need to look for the underlying reason that there is a PED.
Okay, excellent. Good advice. As I said, we're not going to be able to get through all the questions tonight, but what we've done is just touch the surface. Can't say enough. Go to the website, optometry.org.au, download the CPG, look for the other clinical practice guides, but the AMD one is new, it's hot off the press, and it's there for you to download, so please go and look for it. A lot of work has gone into it. It's all been evidence-based, so we look forward to bringing you more of those. Now, we're going to take our final break. When we come back, we've got Colette Kinsella talking to us about Macular Disease Foundation. Stay tuned.
The Find an Optometrist search function on our two websites, our corporate website and our consumer website, attracts almost 50,000 searches for an optometrist a year. Can a prospective patient easily find you? It is important that your membership details are up to date, as search results take your information from the member portal and serve this to consumers searching for an optometrist near them. Updating your information is easy. Simply log into the member portal, check your details and update any incorrect or missing information. And don't forget to include a profile which will appear on search results served on our Good Vision for Life website. Thanks for working with us.
Welcome back for our final segment on AMD and update from Optometry Australia. Tonight we're happy to invite Colette Kinsella from the Macular Disease Foundation Australia to talk to us a little bit about the foundation. Now, Colette has over 25 years of experience in the pharmaceutical and optical industries. She has a background in nursing and she's worked with optometrists in the past, so she's got extensive experience working day to day with optometrists as well. Colette regularly represents the Foundation at optometry and ophthalmology events and speaks at conferences and community events about the important role of the Foundation, raising awareness about macular disease and the importance of regular eye examinations. And she's always been a friend of Optometry Australia. We look forward to hearing from her this evening. Welcome, Colette.
Thanks, Simon. Thank you. And good evening, everybody. And I'd like to thank you, obviously, on behalf of the Macular Disease Foundation for giving us the opportunity to present tonight. Earlier on this evening, you learnt about the new clinical practice guidelines of AMD patients. And in the guidelines, we do actually look at the holistic patient care and working together for better patient outcomes. So the question I do ask is, if you can imagine that it was your mother or your father, or your brother, your sister, or your child that actually had a disease of the macula, how important it would be that you give them access to every single bit of care, whether that's clinical or the non-clinical care. So that's my question to you all tonight. So we're going to go through the program, and the program tonight is, so I'll just give you a little bit of brief about the Macular Disease Foundation. We'll go through some research findings, and then obviously I'd like to really work with you on how we can help you and your practice and increase your referral base. And then we'll look at some referral pathways. So if we're going to look at the foundation, about 15 years ago, we were called the Macular Degeneration Foundation. And we changed our name to the Macular Disease Foundation. That's really important for you all to know tonight. But as the national peak body, our purpose is to help reduce the incidence and the impact of macular disease in Australia. So what do we actually do? We've got an incredible helpline, our national helpline, Monday to Friday, and we can be on the call from for 15 minutes, 20 minutes to over an hour with the patients, talking about the disease information that they have and maybe nutritional and lifestyle needs. We do education seminars around the country. Now that is to eye healthcare professionals and also to the community. We talk about navigation of the government services. Now that might be NDIS or My Age Care, and then through advocacy. So we are actually a good voice for the community. To date, we've given about $3.6 million in research. But one thing I do want to stress is that when your patients do connect with us, should they need to go through and to other services such as low vision services, we actually will guide them and take them through each step of their journey, and then we will advise when they need to be referred onto their low vision services providers. So we want to complement the work of the eye healthcare professionals. So we want to increase, our role is to increase the awareness about the importance of having regular eye tests and those comprehensive eye tests and building a relationship with you. So the patients, it's really important that when they connect with us, we do make sure that they have that relationship with you as an eye healthcare professional. Now, over the years, if we look back in 2007, there was about 33% of people, so that's 1 in 3 were actually having a regular eye test, and that's for the people over the age of 50. In 2016, when we look at these figures, we've actually changed the dial. So there's 2 in 3 people that are actually having a regular eye test today. So that actually looks at the impact that we have made through our national campaigns in driving people back to your practice to have a regular eye test. And as we've learnt this evening about the future direction and the progression of AMD in particular, that in about 2030, we're looking at about 1.7 million people that will have macular degeneration. So, you know, we are doing our best to drive people to practice, get their eyes tested, and these figures I've gone through tonight are people over the age of 50 that are getting their macula checked every 2 years. In 2017, there was some research that was done, and quite interesting research, about 94% of optometrists are aware of the foundation. Some still, like I've mentioned before, call us the Macular Degeneration Foundation, but we are the Macular Disease Foundation. About 40% are aware of the resources that we do provide. Now, we have got a depth and breadth of resources and fact sheets, you know, whether that's on our website, you know, we obviously building a lot of resources for you to hand out to your patients. But as I mentioned before on my previous slide, there are a lot of people that we are driving to practice, but sadly, there's only about 8% of the eye healthcare professionals that actually refer people back to and recommend the foundation. So my questions went over the past 16 months when I've actually engaged with a lot of optometrists. What are your reservations about referring people to us? And questions I get asked are, what are you going to share? What information will you share with my patient? As an eye healthcare professional, many of you say you tell your patients everything that they need to know about the disease. You give them the resources and the brochures, and you certainly do engage with the family members. However, my question to you is, how long do you spend with the patient once they've been just newly diagnosed and their family member? How much information has the patient actually heard or understood when you're actually telling them about they've just been newly diagnosed? And how many patients and family members are you getting back as a referral through that consultation?
5 minutes.
So how we can help you? We can save you time. So if you think back to those patients for the 30 minutes that you may spend going through the diagnosis, we can save you time, and we can obviously help build that referral database. When people connect with us, they are very appreciative, because we can take obviously the longer period of time. And we do actually ask each and every one of them, do they have family members, and to go back and have that comprehensive eye test with you as the eye healthcare professional. So we're talking about holistic patient care. So another question, when should you refer people to us? Upon diagnosis, as early as possible, or whenever you refer to an ophthalmologist or low vision services? It's all of the above. We would like to connect with the patients as soon as they are diagnosed, and obviously we are very careful about including the correct information at the right time. So just guiding them through their disease journey. Some of them through early stages may just want some research updates. So I wanted to make it really easy. So we're currently working on various referral pathways, and a couple of them I'll go through with you tonight. So one, Optimate, Oculo, our website, and then a referral letter. So trying to make it a simple process, because a lot of people take resources home, but they don't call us. So taking away that guesswork, it's if you refer to us, then we can actually follow the patient up. So if we look at the Optimate Touch program first. So the Optimate Touch, many of you have got the Optimate system in your practice. It's literally looking at the patient's screen, and then you can go to the letters section, or you can actually set up a refer to, which makes the emailing and the referral pathway a lot easier. Then through that you can select the Macular Disease Foundation template. You can enter the description, you can add any information that you need to, and then simply save and close. Lastly, then you just select the letter and then you email it to the referrer, which will be obviously the Macular Disease Foundation. You can make any edits or changes and then send that through to us. Once we receive the referral, then we will follow up with the patient and take them through and ask certain questions and answer questions that they may have. The second platform that we're looking at the moment is the Oculo platform. Now, we are actually just working with Oculo to introduce this. Some of you may be familiar with this system, but we are looking to work with him very shortly, but we're still in those sort of final details. This is a very simple process, and a lot of people want to know, do they have to refer at the same time they're referring to an ophthalmologist? We are looking at making it a referral process from the initial diagnosis. So you put in the patient, click on the patient support services, and then you register the patient with us. Once we've got the registration details of the patient, we then can follow up with that initial phone call. And finally, we've got the Macular Disease website. We go into resources, you scroll down to refer the patient, and there's a simple referral process. Your practice details, your name and your address, and then certainly the patient's name and address, phone number and email address, so we can follow up with the call. The referral letter is exactly the same process, just obviously many practices do like to use that hard copy. So in closing, a message to take back to your practice. Macular Disease Foundation are the trusted go-to experts for the macular disease community. We have to work together for better patient outcomes. If we think about holistic patient care, you are the clinical support providers, and we will be the non-clinical support providers. So we want to help you with increase your referrals and certainly save you time. So I'd like to say on behalf of the foundation, thank you very much indeed, and we will have a great opportunity to affect change. Thank you.
Thanks, Colette, and congratulations on all the amazing work that the foundation does. Yes. I think it's an incredible achievement, and it's certainly something that a lot of the members need to look at, optometrists need to look at around sort of, for their patients. We had one question from the audience asking about whether or not interpreters are available at the foundation.
Yes, we do. Okay. Yes, yeah. We've got literature in about 7 or 8 different languages. Excellent. Which we can obviously email out, or they're actually on the website. But certainly, if people do need a translation,
that is available.
We can organise it. Yes.
Yep.
Yeah.
Someone's asking, how quickly do you get back to the patient after we submit the request?
Well, obviously, depending on the time of day that we do get the referral, then we would be as a priority. About within 2 to 3 working days, we'd actually call the patient back.
Good to know. I want to thank you again for all of you for the time you've put in your presentations, how informative and how well it's all been delivered. I think our audience have really appreciated and enjoyed the webcast, so thank you for that. For those of you at home watching, still with us, this will be available as a recording, as I said, on our website. So if you've missed anything or want access to particular slides or listen to a bit more of the explanation around any of the individual slides, feel free to download those or watch those on our website in the coming days. You won't be receiving your CPD points automatically at the moment. What will happen is that you'll receive an emails inviting you to answer multiple choice questions based on Angelica and Carla's presentations. And you'll have, I think, roughly a 2-week window to be able to answer those questions. At the end of those 2 weeks, if you answer those questions and get a 70% pass mark or greater, you'll be accredited with 4.5 CPD points. If you choose not to do the questions or don't get the 70% required, then you'll be credited with 3 CPD points. So this will happen in the next couple of weeks. So I know some of you log off and go straight to the member portal and look for your CPD points. We'll offer you obviously a chance to answer those questions in the next couple of weeks, and then we'll allocate points accordingly after that. Thank you again. We look forward to seeing you next month for our next webcast on cultural safety. Stay tuned and see you next time. Bye-bye.